Good morning, students. We're going to cover chapter 28 today, bipolar disorders. So let's jump right in. Okay, so what are bipolar disorders? Well, bi meaning two, and poles meaning, I guess we could talk about like the North Pole and the South Pole. They're two extremes. Okay, so when we talk about bipolar disorder, we're talking about extremes in mood. Okay, so when you have a patient that has bipolar disorder, we're talking about an extreme mood, for example, in euphoria. Okay, a patient who is super elated. All right, so and we call that mania. When they're manic, they're super euphoric. They may have a lot of energy. They're racing thoughts. They also are erratic and impulsive in their behavior. They could have spending sprees. They go out and they shop and they'll take credit cards and run up credit cards. And they can also be very impulsive, as I said, and do things that maybe they didn't really think through. For example, maybe try to hurt themselves or hurt someone else. Okay, and also you might see some sleep disturbance. So that's on one end of the pole. On the other end of the pole, we could have them go from a euphoric state to all of a sudden they have depression, a depressive state. Okay, where they feel sad, gloomy, and down, unhappy. Okay, so that's basic bipolar disorder. Now, what is the cause of bipolar disorder? Well, it's believed that there's a dysregulation in the amount of dopamine that is created by the body. Too much um, dopamine is created. Also, there are dysregulations in norepinephrine and GABA, and also serotonin. So we have this dysregulation in these neurotransmitters. Okay, and let's go to the next slide, number 4. Oops, I think I went up too high. Sorry, guys. Hold on a second. All right, so bipolar affects approximately 1% of the population. The Usually this is from 2 to 2.5 million people. And slide number 5. The When we look at morbidity and mortality of these patients, it's pretty high. The morbidity and mortality rates usually, well, the numbers aren't really important, but just they are high, and they're usually related to cardiovascular, cerebrovascular, and other psychiatric illnesses and substance abuse, because these patients, being that these levels, for example, of norepinephrine, dopamine, are not so much elevated, but dysregulated. I'd like to use that phrase better. Could be higher at times and then other times. You have a tendency to have then cardiovascular problems and cerebrovascular problems. And these patients, because they are ill, they sometimes like to self-medicate. They have an illness, okay? And at times also, I told you that they can be very impulsive. So you will see that 15% of uh, of the bipolar patients, rather that the risk of suicide and bipolar illness is 15%. That's just what I want to say. Now, the only other category that has as high a rating is anorexia, but bipolar is the highest. All right. So medication adherence is very important with these patients, because these patients do not want to take medications at times, because they can now they like that euphoria that they feel. Okay, they like being, kind of high with a lot of norepinephrine, a lot of dopamine flowing, dysregulation in serotonin. They like that, so they won't take their medications so that they could remain like that. Okay, in that euphoria, they enjoy that experience. These patients, remember, can also be very grandiose. They think of themselves as more than what they're not. They can come up and say that they're an angel sent from God to bring good tidings to men, or something like that. Anyway, bipolar 1. Let's look at bipolar 1. So in bipolar 1, we have a patient who is very elated. They can get manic. Like manic means like they basically they get very elated, euphoric. They may have impulsive, disorganized behaviors, and they'll just do things that you might not expect. Very sporadic and disorganized at times. All right, so they can have grandiosity, and you might see some micro depression, or maybe major depression, not too often with patients with bipolar 1. So we'll see patients that don't really sleep a lot, have a lot of energy, and a patient that's very erratic in behavior and very intrusive at times. A patient like this will come to the nurse's station and say, nurse, I need my meds, I need them now, I need them now. And then you'll say, okay, Mr. Jones, I'll go get your meds. And then they'll go to the day room, and another, maybe the nursing attendant will say, okay, sit down, Mr. Jones, it's time to eat. Okay, I'm going to sit, I'm going to eat. And then they'll sit down, and they'll just sit there and they'll fidget, and they'll say, okay, I got to take my meds, I'll be right back. And then they'll start heading to the nurse's station. And when they see the nurse will say, hey, Mr. Jones, hi, I have your meds. Oh, no, I got to see the doctor. It's very important. And then he'll see the social worker, and then he'll get sidetracked. And then he'll say, are you going to meet with me today? And then he'll get sidetracked, and he'll lose his train of thought. And then the social worker will say, yes, Mr. Jones, we'll meet later. Okay. I wanted to meet you now, but later's okay. And then he'll go back, and he'll go back into the day room, and then the nursing attendant will tell him, hey, Mr. Jones, sit down and eat. And then he'll go to sit down. He says, oh, my meds. And then he'll get up. So very sporadic behavior, very impulsive, poor boundaries, will interrupt you if you're talking to someone, and can also jump from one topic. The way that the thoughts run, can jump from one topic to another. Very pressured speech, as I showed you, and the behavior is very erratic. Now, so for the classification, this is on slide 8. In the classification of bipolar 1, how do we classify this one? So we're talking about bipolar 1 is manic episodes. These patients basically just have manic episodes. These are bipolar 1 manic. That's what they call it. And So they have one or more manic episodes times 1 week. Okay, so during the week they'll just have be manic. Now bipolar one mixed episodes. Now these patients have the bipolar one, the manic, but it alternating with major depression. Okay, so bipolar one manic and bipolar one mixed. That means that they can get depressed, major depression. Okay, so we'll see that in the bipolar one. Um, Now we know that in order for an illness to be categorized as a disorder, it has to impede in occupational, social, and basic relationships. Okay, when it becomes a problem in any one of those three areas, then we say that this disorder necessitates hospitalization, especially if the patient is in danger of harming themselves or others. Hypomania. Hypomania. So hypolomania. So hypomania is a phrase that we use to describe a not a very manic state. It's it's not normal and it's not manic, it's in between. Okay, you can look at it like that, in between a normal state and a manic state. So these patients will have energy, may not sleep as many hours as usually one would sleep, not really disorganized, just able to think things through according to them. They have, they can in a hypomanic phase, you can kind of function in a sense. You could get things done, but sometimes people in hypomanic phases may also be kind of disorganized. If it gets to uh, that point, they can also be disorganized. Um, Hypomania can occur before or after depression. Now, I'll tell you why we're mentioning hypomania. Because and in bipolar 2, right, this disorder, we see major depression, right, and at least one hypomanic episode, all right, before or after the major depression. And this usually, the hypomania is not to that extent that it impairs functioning, and the depression, eh, possibly, but not. But the hypomania doesn't impair functioning, so they don't really necessitate hospitalization. Um, uh, I've had, getting back to bipolar 1, I once had a gentleman who was bipolar 1, and he took $25,000 out of his grandmother's bank account, and went to Las Vegas and just started gambling for about 5 days. Gambled and drank and just spent money. And eventually, he wound up trashing the room, and then he became very impulsive, and so they called of course, they called the police, and they brought him back to New York. Uh, Also, I had a bipolar female one time, and these are just some that I mentioned. There's others, but this one, she when she would get manic, she would go out, and during your manic phase, you can become very sexually promiscuous. Again, very impulsive. You do things, drugs, etc. So she would go out, and then she'd bring home men. And she was married, had 2 kids. So she would go out, bring someone home, and have sex with them on the couch while her children were watching TV. Her two children were watching TV. Very promiscuous and very impulsive. in the manic phase. While she was in the hospital, she seduced a young man, and they had sex in her room, which became, was kind of a liability issue for the hospital, because what if she gets pregnant, etc. So it was touch and go with that patient. But as I said, they could be very erratic, very impulsive. All right, so that's cyclothymic disorder. It's like bipolar 1. You have numerous periods of hypomania, but you have hypomania and dysphoria, which is a lower degree of depression. It's not major depression. You just kind of feel like gloomy. So you have hypomania and dysphoria, cyclothymic. Okay, bipolar 2, you have hypomania, major depression. Bipolar 1, mania, that's manic. The manic, bipolar 1 manic is just pure mania. Bipolar 1 mixed is mania and major depression. So you see, one, you have just mania, bipolar 1. Bipolar 1 mixed, you have mania and major depression. Bipolar 2, we have hypomania and major depression. And cyclothymic, we have hypomania and dysphoria, which is a low form of depression. Okay, moving right on. Oops. Okay, rapid cycling. Basically, what is rapid cycling? If you hear this phrase used around the clinical area, 4 or more episodes in for at least 2 weeks in a single year. All right, so you have four or more episodes in a year, rapid cycling. The problem with that is that means that these patients aren't responding to the psychopharmacological therapeutic treatment range. All right, so what care settings? We have acute care, in hospital, daycare programs once they're kind of stabilized, and community-based programs. The common modalities of psychotherapy that we use is psychoeducation, cognitive behavioral therapy, and family therapy. The drugs used to treat bipolar disorder, basic first line drug is lithium. It's a mood stabilizer. That's to alleviate the acute mania. We also use anticonvulsants, especially if the mania doesn't respond to lithium. Okay, so, and also used for refractory mania. That's refractory mania that doesn't respond. So we'll have divalproic acid or Depakote, carbamazepine, lamotrigine, and topiramate. All right, we can also use antipsychotics, and sometimes we do, in order to bring the patient down off of that manic phase. So we could use olanzapine, risperidol, Abilify, Seroquel, all right, Zyprexa. All right, assessment of clients with bipolar disorder. Well, when we're assessing, we definitely have to assess these patients for suicide and violence, okay, because they can be very impulsive. So we're going to assess the affect always. We're looking at these patients, seeing where they're at, thought processes as we're talking to them. We're going to assess that, etc. And physiologic, psychomotor, if they're moving around a lot, we could then come and we set limits. Limit setting is a very big tool in psychiatry. Setting limits. Mr. Jones, what's going on? I see you racing up and down the corridor. Is there something I could do for you? No, I have to see the doctor. Okay, I'll let the doctor know. But can you go to your room and rest for 10, 15 minutes? and try to get him to go to the room and relax for a little while, kind of wind down. Okay, these are ways, this is what's called limit setting. You come up with alternatives to the behavior that they're exhibiting. So we also see some impulse control problems that we have to intervene in, aggression. Maybe they might have a problem with another patient, so you might have to intervene in that. And just getting them to be compliant. So as a nurse, what can you do? Well, you could listen. Make sure, because you don't want the patient to think that you're not listening to them. If they're talking to you, you listen, because then they can say, "Oh, you just don't listen to me. I don't want to talk to you," and then they'll just blow you off, and they won't respect what you have to say or do. So you want to listen, and you want to, again, set those limits, especially on overactivity, and maybe they might be sexually preoccupied or promiscuous, which can happen. I once had a young girl who, during a night shift, she got stripped totally naked and started walking up and down the corridor so I could see her. Very young girl too. This was years ago, of course. So we have to set limits on that type of behavior. There's also cognitive restructuring, kind of getting them to think of things differently, because these patients perceive things in a distorted way. Okay, so mood management, self-esteem enhancement, guided imagery, all these could also might work with these patients. Let me just see here. Oh, very important. Remind these patients to kind of, you need to set limits on their behavior, and you kind of have to get them to sit down and eat. Sometimes you might have to sit there with them and kind of force them to eat and drink, because they won't. And rest, they won't do that. They're so wired from the neurotransmitters in their body that they'll go all over the place. So this is very important. Okay. Thank you so much, and that is it for this chapter.